So, good afternoon, everyone. This is our first case. We have named the case as Chasing the Unknown. So, directly going to the case. For the history, 24-year-old male patient presented with involuntary neck movements since 10 years of age and jerky movements in the upper limbs since 15 years of age. So, let's see the video. So these movements.
Left-handed, no problem. I didn't notice in my life that my left-handed problem because I eat and drink and.
So asymmetric movement. Seeing the writing. So that's the problem. And this is the handwriting sample of the patient. So when we took the detailed history, we found a nice family history with almost 4 generations affected. So we asked where the patients stay, and they said our family members stay in a very remote area and they can't come to Kolkata. They stay in some coastal village in Porbandar. So I discussed with my mentor Rishi sir, and thanks to Rishi sir for giving me the inspiration. So we traveled from Kolkata to Rajkot, and from Rajkot to Porbandar, and from Porbandar to there is a village. It's exactly in the very near to Arabian Sea. So we went there. So that's the house where they stay, and they came to meet in a place. So all these are the family members where we saw, and we can see all these are having the symptom. And if we see carefully, there is some intrafamilial variability of the symptoms. So this is a younger patient seeing these movements.
Thanks, Jacky. Should we ask the audience to participate and see what they think about the movements? Anyone wants to? You want to say? Yeah, come to the mic and don't be shy. We are all friends here, more or less.
Seems like dystonia myoclonus syndrome.
So, which part was the dystonia in the first case?
Neck dystonia.
So he clearly had an abnormal posturing of his neck. Then he's got the jerky movements in addition. And whenever you see jerky movements, you ask yourself the question, there are 3 types of jerky movements. Is it myoclonus, tics, or chorea? So you went for myoclonus. But then if you see this video, the first one, can you know, the one on the top there, and you see his hands now.
It's coriform.
That's coriform, isn't it? So that's why there's a little bit of that quandary that if there's a family member here which seems to have more of chorea, while that other family member seem to have more of the neck dystonia and jerky dystonia. Let's call it jerky for the moment.
You can see other videos also in this family.
ठीक है अब बोलिए टा 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 बोलिए का 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 का
So
myoclonus.
So you wonder there whether there is positive and negative myoclonus because there are lapses of tone as well.
And that's how the pupil of Gujarat.
And this is a bit different, right? And what is happening here? That's almost tremor-like. So it's a mixed movement disorder, slightly different in different people. This is a abnormal posture with dystonia and some jerks, yes. Do you want to ask them a question? Any questions you want to ask? If you were thinking myoclonus dystonia, what would you ask as a leading question and say, the family history looks autosomal
dominant.
So autosomal dominant causes of jerky, dystonia, myoclonus. Is there a question you might want to ask?
Phenomena of anticipation there.
No.
No, that's not the question.
Sir,
Anyone?
sir, any history of improvement with alcohol intake?
Any alcohol
Yeah,
improvement?
they don't take alcohol actually. They're
How do you
not-
know? So yes, that would be one question, because myoclonus dystonia, they start very early, and
SGC
if they do drink, then they might have a response to alcohol, quite
Sorry, sir?
significant response. Any other question
No
you want to
ataxia.
ask?
No ataxia.
Any other question in view of that Korea?
Cognitive decline.
No, they don't get this. That's why it's called benign heterogeneity. Not you don't
Sir,
get cognitive
yeah,
decline.
like any difference in involvement upper limb and lower limb?
Yeah, predominantly neck and upper limb
Neck and
involvement.
upper limb. So I would like to vote for SGCE.
DYT11.
But lower limb was also involved in those cases, some of them.
Yeah, so we should never jump to a etiology straight away. So think about the syndrome. Think about syndrome. So if you're thinking one possibility, you said is dystonia myoclonus, and that's usually proximal, right? But then if you got this person with a chorea, what might be another condition which mimics myoclonus dystonia? So that's benign hereditary chorea due to the thyroid transcription factor 1 gene. And then there's a third condition, which is called ADCY5.
Is there any sleep?
Yeah, so then you want to know about the sleep.
Improvement with coffee.
No improvement with
Sleep-related aggravation?
no.
So these would be sort of things you want to be thinking about, and you may ask for a genetic test from that point of view. But it's important that here that phenotype is a bit different in different people. So all these conditions are possible in your differential, but we need to know more. Go on.
Can I check you one thing regarding phenomenology? We have various presentations, but think of index case.
Yeah.
If somebody has this dystonia and jerky movement, when to call dystonia and myoclonus, and when to call dystonia and dystonic tremor only, because we know that dystonic tremor can be jerky also.
Absolutely. Exactly, yes. So dystonia can be jerky. That's the important thing to keep in mind. And some of that you might say is just part of the dystonia, jerky dystonia. But it's proximal in the neck. Some of those people also had it in the hands. Okay.
Proceed. Okay. So this is from Professor Bhatia sir's one of my favorite chart, where this approach, as you were mentioning, this myoclonus dystonia. So in myoclonus dystonia, main catch is whether myoclonus more than dystonia or it is dystonia more than myoclonus. And in this case, the predominant in the index case, we got more of dystonia rather than the myoclonus. So that's a red flag for sarcoglycan. And if you see other history, no psychiatric history for the Relin, no developmental delay, no epilepsy, no cardiac arrhythmia, no sensory loss, no ataxia, as I was asking. So few things are left there. Where GNAL is left, ANO3 is left, KCTD17 was left. So GNAL KCTD17 definitely would come in the differential higher, because in one of those patients you saw that there was spasmodic dysphonia. But in this intrafamilial variability, is a lot of chorea was there in one of them. So choreodystonic, so that's a bit odd. So then went for whole exome sequencing, and we found ANO3, but it was heterozygous, autosomal dominant as we know. So the mutation was heterozygous 3 base pair insertion in the exon 17 of the ANO3. And we went for Sanger sequencing. So if we look carefully in the Sanger chromatogram of the index case, this is actually reverse chromatogram. So we have to read it from right to left. So in the extreme left, you are seeing those double peaks. So double peaks are indicating there is this insertion, heterozygous insertion is happening. In symptomatic, so we collected from that place, we collected 14 symptomatic blood samples. And again, in those symptomatic patients, you are seeing those double peaks in the extreme left. So that variant, that 3 base pair insertion variant was present in all the symptomatic present, and it was absent in all the asymptomatic presents. So we could not collect all the asymptomatic patients. We collected 2 asymptomatic, those we are not seeing that kind of double peak, all the single peaks we are seeing. So the diagnosis was ANO3 related this myoclonus dystonia spectrum, where Korea has been reported. This is a nice paper recently published in MDCP, where they classified with a below 20 year of age and above 20 year of age. In the below, you are seeing all those non-dystonic features. If you see the non-dystonic tremor presentation, myoclonus presentation, some neurodevelopmental delay may be also there when the onset was early. In our index case, the onset was below 20 year and presented with myoclonus dystonia presentation. So that was my case. And we went for GPI DBS very recently. Last month, we did the initial programming for our index patient with bilateral GPI DBS. As we know, in Parkinson's disease, you can see the improvement stat in front of you, but in dystonia, you have to wait for a while to see the improvement. And we just did the initial programming and the second programming, and this is a home-based video. We will see. So as per him, the neck movements are a bit better, but definitely we need to follow up program. He is happy with that. So that was my case. Thank you.
So we had described the initial gene NO3 and you're absolutely right that the phenotype is that of somebody you see with cervical dystonia, which is early in onset, because normally cervical dystonia comes only in the age group of 50s, 60s. So these people are in their 30s, 40s, and they have a lot of tremor. So they have a jerky tremor of the neck or of their hands, or it's jerky. So in those three families we had described in the initial report, there was this variability like you saw. Some people with a neck dystonia, some people with a jerky arm tremor, some people even misdiagnosed as essential tremor. So keep that in mind, but many of these cases are actually misdiagnosed as essential tremor. But only when you see carefully, you see some of the dystonic posturing, and then you must, and if there's a very strong family history. Now this one doesn't respond very well to alcohol. So that's another sort of an indicator. Some of them do, but not all. Not as good a response as you get in myoclonus dystonia in the classic form. And the last thing to say is that you saw some proximal involvement, but also distal.
Yeah.
In myoclonus dystonia, due to the epsilon sarcoglycan, it's only proximal. So that should have been a clue for us because there was a distal involvement.
Sorry? No, this was only by us, self-sponsored. Thank you.
Very well presented case, Jacky. Very. I just wanted to comment that maybe we should look for some kind of a founder effect or something in this population, because we had a similar patient with NO3 from Porbandar who also underwent similar neck dystonia with severe jerks, who we thought initially was myoclonus dystonia. At the time she underwent DBS, we didn't know that it was NO3. Subsequently, as part of a research setting, the genetic testing was done and turned out to be NO3, the same duplication. So maybe this is a cohort of patients from there, and she did motor-wise very well with DBS. But unfortunately, after about 2 years, she had some psychiatric manifestations and committed suicide. So this is something also maybe that we need to, in myoclonus dystonia with SGC, it is known, but no, maybe in NO3 also one needs to screen for.
Thank you.
One quick point over there. So this was one of the craniocervical dystonia and myoclonus. I found a peculiar phenomenon in two patients of such, it's not NO3, that giving Botox injection in cervical dystonia that improves handwriting also. So can you comment on that?
I don't know whether that's just when they're writing, if the neck is involved, their writing is difficult. And if you improve the neck posture, then your writing gets better.